Preoperative assessment in the lung resection patients, the crucial step in anesthesia management. Patient will tolerate one lung ventilation intraoperatively and will have sufficient pulmonary reserve postoperatively. In case of difficult one lung ventilation, feasibility of surgery with two lung ventilation or alternative options for therapy or radiotherapy should be discussed with the surgeon. Commonly performed surgeries for lung cancers include pneumonectomy, lobectomy, wedge resection, and segmentectomy. Complications of lung surgeries, most common includes pneumonia, atelectasis, arrhythmias, and CCF. Less common, MI, prolonged air leak, emphysema, or BPF. These are the changes following the lung resection surgeries. In pneumonectomy, FEV1 reduced by 34 to 36%, FVC reduced by 36 to 40%, and VO2 max reduced by 20 to 28%. As in lobectomy, FEV1 will be reduced by 9 to 17%, FVC reduced by 7 to 11%, and VO2 max reduced by 13%. So for the patients opted for surgeries, we have to do initial evaluation like good history taking, physical examination, chest X-ray, PFT. There is no single measure that there is no gold standard test for predicting complications. So, however, certain criteria when applied have been shown to the predictive of outcome. Smoking is a risk factor for development of postoperative complication. Relative risk of complication after surgery for a smoker is 1.2 to 4.3 fold. Smoking cessation decreases postoperative pulmonary complication. So, surgery should be delayed for 8 weeks after smoking cessation. Importance of CT scan. Evaluate for anatomy of the region of the lung to be resected, relationship of the disease to the adjacent structures, and the possible presence of the disease in the lung tissue that will not be resected. Help to count the segments of the postoperative lung function prediction, which is needed for the perfusion method that is coming later. I'll present it later. Pulmonary specific evaluation includes spirometry, lung volumes, diffusion capacity, ABG, radionuclear lung scanning, and CPET. Postoperative respiratory complications following pneumonectomy increases significantly when FEV1 is less than 2 liters or 80% of predicted, or maximal voluntary ventilation is less than 50%. For a lobectomy patient, FEV1 of 1.5 liters appear to be the critical threshold. The diffusion DLCO has also been identified as the predictor of postoperative complication. Increased risk is associated with a DLCO of less than 60%, that is 60 to 80% of predicted, and appears to be independent from FEV1 as a predictor of complications, morbidity, and death. Therefore, evaluating this predictive postoperative lung function is a crucial point. According to BTE's guidelines 2001 says that absolute percentage of PPO FEV1 of 1.5 liters for lobectomy and 2 liters for pneumonectomy as a selection criteria for surgery. If a patient having FEV1 of 1.5 liters for lobectomy and 2 liters for pneumonectomy, no further test is needed for the patient and we can clear for the surgery. According to ACCP 2013 guidelines, there is they quoted on the importance of percentage of predicted postoperative values, that is percentage PPO over this absolute values. Absolute values when expressed in terms of percentage of PPO may place a low risk patient in moderate or high risk category. Single cutoff of FEV1 cannot be applicable to all the ages, build, races, and genders. Values calculated as percentage of normal predicted value correlate better with the outcome. Percentage predicted parameters are estimated parameters for late postoperative period at least 3 to 6 months after the surgical procedure. As per ACCP 2013 guidelines, any patient plan for pulmonary resection should be assessed for pneumonectomy also. We can do this PPO, percentage of PPO can be calculated by two methods. One is anatomic method and the other is perfusion method. Anatomic method, actually CT scan is helping in doing this anatomic method. PPO of FEV1 is preoperative FEV1 into 1 minus Y by Z. That Y is the number of functional lobes that we are planning to remove, or Z is total number of functional segments. Postoperative percentage predicted postoperative value of DLCO includes preoperative DLCO into 1 minus the same thing Y by Z. Other one is perfusion method that we are doing with ventilation perfusion scanning. PPO, if that's equation is percentage of postoperative predicted postoperative FEV1 is preoperative FEV1 into fraction of total perfusion of the lung, resected lung, and the DLCO is preoperative DLCO into 1 minus fraction of total perfusion of the resected lung. All this doing with the help of ventilation perfusion scanning, and we can calculate it as percentage also. So if the FEV1 and the DLCO is more than 80% of the predicted, we can clear for pneumonectomy. With no history of ILD or dyspnea on exertion. And if the FEV1 or the DLCO is less than 80% of predicted, we have to calculate the PPOs for FEV1 and DLCO. If the PPOs PPOs of FEV1 and the DLCO of more than 40% of predicted, we can clear for pneumonectomy. If the predicted post-pneumonectomy FEV1 is in between 30 to 40, we can categorize into borderline. So in this patient, we have to perform CPET. This I'll present this mainly on this topic on 1st of May. Then predicted post-pneumonectomy FEV1 is less than 30% of predicted, then that there is a high risk of pneumonectomy. If in the case of high risk of pneumonectomy, we have to calculate predicted post-lobectomy FEV1 and DLCO. If it is more than 40% clear, we can clear for lobectomy, and it is less than 40%, there is high risk for lobectomy. So alternatives for CPET includes 6-minute walk test, stair climbing test, and shuttle walk test. 6-minute walk test, the very low technology test with no standardization, should not be used for preoperative assessment. Stair climbing test, it's a first-line functional screening test to select patients. If the height of the ascent without any discomfort more than 22 meters, then the patient is fit to undergo pulmonary resection. But there is lack of standardization of this test. Demonstration of patients' ability to climb 5 flights of stairs predicts more than 20 ml per kg per minute of capacity is there. So patients who are unable to climb 1 flight of stairs have less than 10 ml per kg per minute. An ability to climb 3 flights of stairs reliably identifies patients who are likely to heal well after lobectomy in spite of having predicted postoperative FEV1 or DLCO that is less than 40% of predicted. Shuttle walk test. In this test, the patient walks back and forth between 2 markers set 10 meters apart, and the walking speed is increased each minute in a graded fashion paced by a audio signal. If the patient is too breathless to maintain the speed or unable to maintain the pace or desaturation less than or equal to 85%, the test is discontinued. A patient unable to complete 25 shuttles or 250 meters on 2 separate occasions indicates a reduced maximum oxygen consumption of less than 10 ml per kg per minute. If the patient can complete 400 meters on shuttle walk test, then the patient is fit to undergo surgery. This is the one journal I have seen, that is 2018 anesthesiology, clinical pharmacology, one journal that is based on clinical practice guidelines by HCCP, BTS and ERS. In that they have mentioned just level 1, level 2 and level 3. Level 1, how to do PFT and DLCO. If the percentage PP of FEV1 and DLCO is more than 60%, we can clear the patient for lung resection. If it is between 30 to 60%, that patient, that is borderline patient, that have to be go to level 2 test. That includes shuttle walk test and climbing test. If the climbing test more than 20 meters and the walk test more than 250 meters, these patients can undergo lung resection. If the climbing test and walk test, if it is less than 20 meters and the walk test less than 250 meters, in these patients we have to do CPET. And these patients are high risk for sublumbar resection or non-operative treatment, and that patient have to undergo non-operative treatment options. If the patient percentage predicted post-operative value FEV1 and DLCO less than 30%, this patient can directly go for level 3 test. Then with bronchodilators, corticosteroids, antibiotic, chest physiotherapy, smoking cessation, ideally a minimum of 8 weeks prior to the surgery. Patient education is important, like deep breathing exercise, importance of coughing and pain control, use of incentive spirometry. Consider inspiratory muscle training also. So conclusion, if a preoperative FEV1 and DLCO is more than 80% of predicted normal, the patient has no dyspnea or any features of interstitial lung disease, the patient can clear for pneumonectomy, no other test needed. If the preoperative FEV1 and DLCO less than 80% of predicted normal, this patient has to go for calculation of predicted post-pneumonectomy FEV1 and DLCO. If the predicted post-pneumonectomy FEV1 and DLCO are more than 40%, the patient can clear for pneumonectomy and no further test is advised. If the percentage PPO FEV1 is less than 30% predicted, then the patient is considered as high risk for pneumonectomy. If the patient is considered at borderline for pneumonectomy, then we have to check the percentage PPO FEV1 and DLCO. If it is between 30 to 40%, then exercise testing should be done. Borderline patients with more than 15 VO2 max of more than 15 ml per kg per minute are cleared for pneumonectomy and no further testing is advised. While patients with less than 15 ml per kg per minute are considered as high risk for pneumonectomy. If the patient is determined to be at high risk of pneumonectomy, the predicted PPO of FEV1 and DLCO should be determined to inform conversations about the risk and benefits of more limited surgical resections or non-operative treatment options.